Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello and welcome everyone to the Sleep is My Waking Passion podcast. I am joined by literally a legend in the sleep field, Dr. Atul Malhotra. So welcome, Atul. It's so wonderful to actually have you on the podcast. This is really awesome.
Thanks for having me. This is exciting.
So I'm going to just introduce Dr. Malhotra. He is very well known in the sleep community. He is a leading expert in sleep medicine, pulmonary critical care. He is a professor of medicine and director of the sleep medicine program at UCSD. He has done some groundbreaking research, including most recently being the first author in publication regarding Tirzepatide, also known as Mounjaro, which a lot of people are getting excited about, and, has discovered some really interesting things about obstructive sleep apnea over the years. He's gotten over 300 peer-reviewed publications. He is a respected authority, and he also is the 2024 recipient of the Sleep and Respiratory Neurobiology Lifetime Achievement Award from the American Thoracic Society. So that's pretty, you guys are going to be hearing from a true legend in this space. And so I want to learn just as much from him as I'm sure you do. So it's
I do as well. Who is this guy? I want to meet him.
So I feel like I did see a little bit of baseball, and I know how much you love it. So I will say I was curious as to whether or not you think the Mets are really going to be able to pull this out, because I normally don't watch baseball, but I thought of you because I know how much you enjoy sports. I just had to ask what your thoughts are. I don't think they could do it. I really don't, but I don't know.
I'm a hardcore Red Sox fan, so I'm a little bit unhappy these days. And then I became a Padres fan when I moved to San Diego, but no such luck. So I'm watching football these days.
Fair enough. So I really wanted to pick your brain about some of the newer innovations for obstructive sleep apnea, and in particular, kind of where you think things are going to go, because a lot of people can't tolerate machines, the CPAP machines. And now there's pharmacotherapy, meaning medication to treat obstructive sleep apnea. And just based on your recent publication in the New England Journal, maybe you could talk a bit about Tirzepatide to start, because a lot of people have questions about it and are sort of obsessed with the idea of being able to take something that treats not only sleep apnea potentially, but also their obesity.
Yeah, let me clarify your question a little bit, if I may. So you said many people don't tolerate CPAP. In fact, I would argue that the majority of them do tolerate CPAP. If you have a dismissive attitude or defeatist attitude saying nobody tolerates it, then of course patients will not. But we've published with the MedX Cloud and academic industry partnership, we've published 70% of patients getting usual care will meet U.S. Medicare criteria for CPAP adherence. If they get modern technology with active patient engagement, get up to 87% adherence. And so the idea that nobody tolerates CPAP is simply not supported by data. If you give it to patients and say nobody tolerates it, then of course they won't use it. But our goal with the new research is not to displace existing therapies, but to add to them. So the Tirzepatide paper that you mentioned was recently published in the New England Journal of Medicine. Tirzepatide is a GLP-1 receptor agonist, glucagon-like peptide 1 receptor agonist. It also works on GIP, which is gastric inhibitory peptide, also known as glucose-dependent insulin-tropic polypeptide. It's a mouthful, but Tirzepatide, also known as Mounjaro or Zepbound, given once weekly by injection, has been shown to improve body weight. And so initially got FDA approved for diabetes and subsequently got an approval for obesity. And we recently showed in a randomized controlled trial that Tirzepatide could also improve sleep apnea in people with obesity. There's a couple of points to emphasize. One is we did 2 randomized trials, one of non-CPAP patients who either couldn't or wouldn't use CPAP, and they got Tirzepatide or placebo. And the study 2 was CPAP-treated patients who got either Tirzepatide or placebo. So we had no direct comparison of Tirzepatide and CPAP, even though it's tempting to make those kinds of conjectures, but the bottom line is we showed Tirzepatide is better than placebo from the standpoint of sleep apnea severity. But also all of our secondary outcomes were pre-specified, and all of them were controlled for multiple comparisons. So we showed improvements in body weight, about 20% body weight improvement, which is huge. Systolic blood pressure got better. Sleep apnea severity got better. High sensitivity C-reactive protein, a cardiovascular risk marker, got better. And patient-reported outcomes got better as well. Both daytime symptoms and nighttime symptoms got better by patient reports. So everything went in the right direction. And so it was gratifying to see the improvements. But again, we didn't change the standard of care or first-line treatment. We just added to the armamentarium of available therapies.
Can you explain hypoxic burden? Because some people may see that. I think from the sleep perspective, we really care if someone's dropping their oxygen very low. Can you explain that a little bit and how that might be of a significant finding with the study?
Sure. So Ali Azerbaijan is a co-author of the paper, and he's probably done the best work on the hypoxic burden. What that does is quantify the area under the curve for desaturation. So rather than just looking how low does the saturation go, it takes into account both the time and the duration of the fall in oxygen levels. So if you go to a saturation of 80% for 2 seconds or 80% for 2 minutes, that's obviously a very different thing. But if you're just counting the nadir value, they'd both be 80. And so this takes into account that area under the curve. And Ali has shown in several different analyses that it may be a strong predictor of cardiovascular risk. And so we did see major improvements in the sleep apnea specific hypoxic burden with tirzepatide compared to placebo in both the non-CPAP arm study 1 and the CPAP arm study 2.
Wow. Okay. So do you think that this has potential implication in terms of reducing cardiovascular risk? Like how we always kind of look at the number of the apnea-hypopnea index, or the number of times that people either have stopped breathing or almost completely stopped breathing. But there's more and more literature coming out that says, hey, the degree to which you drop your oxygen levels, and obviously for how long, actually is kind of important to you. Do you have any thoughts on that in terms of how we're going to even look at sleep apnea in the future? Because it sounds like we're starting to really question whether or not we've got it figured out just by the apnea-hypopnea index.
Yeah, it's a good question. And, sleep apnea has been associated with a myriad of different complications. So there's, potentially cancer risk, potentially Alzheimer's risk, potentially cardiometabolic risk, peripheral neuropathy, motor vehicle accidents. And it would be shocking if one yardstick were to predict all those different complications across multiple biological systems. So the apnea-hypopnea index is good, but not great. And of course, it doesn't predict everything, nor would you expect it to. One yardstick can't predict 18 different things. It just wouldn't expect it to. So part of this will come down to what's your outcome of interest. If you're very interested in Alzheimer's risk, then there's some factors that may be predictive. If you're interested in cancer risk, it may be quite different. So, for example, Naresh Punjabi in Miami has shown that 4% desaturation predicts hypertension, 2% desaturation predicts insulin resistance. We've shown the duration of saturation below 90% predicts platelet aggregation. The frequency of arousals through sleep seems to predict memory consolidation. So it depends on the outcome of interest. And so one yardstick's not going to predict everything. Suffice to say, what we saw in the SURMOUNT-OSA study wasn't just an isolated improvement in the apnea-hypopnea index, which you could question what that means. But we saw concomitant improvements in all of our pre-specified secondary outcomes and in patient symptoms. So we didn't just make the numbers look better, or look one number look better. We got everything looking better, including systolic blood pressure and high sensitivity C-reactive protein and hypoxic burden, as he mentioned. So everything was going in the right direction, which is quite reassuring.
I think the point that you made about how you view CPAP really influencing the success rate is so very key, because you really highlighted that, and I've often seen this with patients, it's really important as me from the perspective of having a patient with sleep apnea, not kind of talking badly about it. And I agree. I think it's a great tool. And I even encourage some of my patients who have, quote, more mild disease or fewer events. There's limitations to the accuracy of that on a home sleep apnea test, which is often what information I'm getting. But also, too, I try to look at their symptoms. And I say, don't discount it, because it really can help. And I've had some patients that are so mild, at least in theory, on their testing. And then I treat them and they're like, oh, my God, I feel like a new person. So it really can be quite wonderful. So, and I have noticed that patients who come to me who have had other people in their lives, be it friends or family members, who have not done well with CPAP tend to come with that mindset. Like, this isn't going to work for me. And
Yeah.
just to share with you a quick story, I actually had a patient who went through the process of didn't like CPAP. We went to an oral appliance. I really thought good jaw mobility, kind of a thinner guy, maybe he'll do well with it. That didn't seem, he didn't love that either. And then he actually went to Inspire therapy, which, guys, I've talked about on the show, which is an implantable stimulator for the hypoglossal nerve to kind of get the tongue to move out of the way, which is a surgical procedure. And even then, he sort of was very sensitive, even though they tried to tweak the settings. And ultimately, he ended up back on CPAP. And he was happy with it, but somehow he needed to go through all of the permutations of treatments at the time to figure out that he was going to land on CPAP.
Yeah. I saw a patient yesterday who did exactly the same thing, went through every different treatment, tried the Inspire, tried and ended back on CPAP, and he's a happy camper as of yesterday. So that, I see that as well.
Isn't that wild?
Now, regarding the thing you said about mild sleep apnea, I'd like to respond as well. And it's a bit of a personal anecdote, but a close personal friend of mine had an apnea-hypopnea index of 7, which is sort of a borderline abnormality, considered mild sleep apnea. And she looked me in the eye and with almost, emotion said, I want you to never use the term mild sleep apnea again. This was ruining my life. And I got on treatment with CPAP. It changed my life. My husband was back in bed with me. I felt better. I didn't realize how dysfunctional I was with mild sleep apnea. And she said, never use that term again because it wasn't mild for me. And it was a good lesson learned because I was flippant about it, saying, oh, it's a trivial abnormality or it's barely abnormal. But for that particular patient, who was a personal friend, it was ruining her life. And so treatment in her case was a home run.
And you know what? That points to how I've modified my practice, and this is one of the things I'll encourage if I do have any listeners who happen to be clinicians, keeping up with the literature and how people are evolving in their thinking, I think can be so helpful. Because I used to emphasize, this is mild. This is like, I would just be so almost dogmatic about it because that was what my fellowship was. And at the time it was felt to be very significant. And now I say, let's really look at how you're feeling. Because I, again, have seen, proof is in the pudding. Like, sometimes we have to be able to evolve ourselves as just the research evolves. So thank you for doing that
Right.
hard lifting with the research.
Right.
I'm learning a ton.
Right. And, I think the other part of the lesson learned for me, which I knew before, but worth emphasizing is, shared decision making. So I can look at numbers and say, oh, this is mild. But if I don't talk to the patient about it, how do I know it's mild for them? It's sort of one of those things that it's, a little bit broken to look at a test result and decide how to manage the patient without including them in that conversation.
Oh, truer words have not been said. Seriously. Where do you think a medication like Tirzepatide, how do you think it's going to fit in to how we as sleep specialists are going to modify our treatment? Do you think there's going to be still I do think people need to get on treatment, right? You don't take Tirzepatide and magically you're 20% less body weight. In fact, you'd probably want to go slow to make improvements and not lose too much muscle and, be thoughtful about how you're taking these medications. So I think, especially for patients that are very symptomatic, as we're discussing, CPAP's really going to be important for them. Using a machine is going to be important for them. But I'm just curious where you think this will fit into the algorithm. Do you think it'll be something that we say, okay, you also happen to be obese, and this might really benefit you in terms of these other markers? What are your thoughts on that?
Yeah, the answer is I don't know. This is an evolving area. We submitted to the Food and Drug Administration for approval, and if we get a on-label indication for Tirzepatide, I think that would be important for people to take into consideration. On the other hand, in my view, the standard of care hasn't really changed. So 10 years ago, the Chernos paper was in the New England Journal of Medicine looking at treating either body weight or sleep apnea or both. And I think the most important conclusion was that treating both was probably what was helpful in terms of lipids and blood pressure and metabolic function, the rest of it. And so for me, the standard of care has always been treating both, not treating either or. And I think many of us were probably sloppy. If you just hand a person with excess body weight a CPAP machine and don't address the underlying cause, which is the body weight, to me, that's a little bit like a pulmonologist giving a COPD patient bronchodilators and not talking about smoking. cessation or something. You're not treating the underlying cause, and that's really not good medicine. So what hasn't changed is the standard of care. That's when we treat the whole patient. Diet, exercise, and sleep are the three pillars of health. That hasn't changed. And treating patients' sleep apnea and their body weight, I think, is still the standard of care. What's different now is we have more effective approaches to treating body weight. What I often say is if diet and exercise were highly effective, I would be skinnier because that's what I do. And I'm not as skinny as I would like to be. And so Tirzepatide is a good tool in the armamentarium to help influence body weight. Obviously, it's cost effectiveness questions. Are we really improving heart cardiovascular outcomes? We don't know that yet. Although, everything's going in the right direction. That provides some reassurance that this would be a good tool in the armamentarium if people need help losing excess body weight.
Do you think that in addition to just having pharmacologic therapy like Tirzepatide, potentially, for obesity, I'm just wondering, in terms of from the clinical side of things, how we start to incorporate this into our armamentarium when I think there tends to be, I think what's equally important in this is the component of what are you consuming and how are you consuming it? And are you exercising to maintain muscle mass on this journey of weight loss? And I kind of feel like that sometimes gets a little bit left behind when we're focusing just on medication. And, I'd like to see more sleep doctors get comfortable with prescribing these medications, but I also have concerns that if we don't have a backup plan for educating with diet and exercise, I'm not sure what the solution is, because I kind of feel like that's where maybe there's not as much foresight that's put into medicine. We tend to be more reactive. And I was just wondering your thoughts. I mean, my initial impression is maybe a multidisciplinary team, but, it sure would be nice if there was some way to protocolize this and make it actionable, but yet also affordable to do, with our healthcare system being what it is.
Yeah, you raised several important points there. First, I should give some disclosures, and that is, I'm a paid consultant for Eli Lilly as the global principal investigator of the CPAP OSA study. I also have some friendship with the ResMed company that is part of the Medics Cloud. I don't take money from ResMed or from Medics Cloud, but they did give a financial philanthropic donation to UC San Diego, where I work. So I should make a couple of points. Number one is the GLP-1 receptor agonists do affect muscle mass, as you're suggesting. And so if I just starved myself, if I just stopped eating, I would lose fat, but I'd also lose muscle. When you lose skeletal muscle, that's what drives your basal metabolic rate in terms of burning calories. And so it becomes very hard to sustain weight loss if you don't have skeletal muscle. So what you're saying is absolutely correct, and that is, diet, exercise, and sleep all need to be targeted together, not just stop eating, because that doesn't work. So all these companies now are working on agents to try and maintain skeletal muscle. And it looks like, people can sustain the weight loss if they continue on the treatment. And in some cases, clinically, I've seen patients able to sustain the weight loss, but it involves strength training, resistive exercise to maintain skeletal muscle. That said, the GLP-1 receptor agonist, the long-term adherence has been a source of discussion. People that use their GLP-1s also seem to use their CPAP because they're probably healthier people who are more educated. And so that's good in the sense they're not choosing one therapy over the other, but they're treating both. And so I think, some of the future of this is a little bit unknown, but I think at least now we have more effective therapies in our armamentarium, which we can use, moving forward.
Do you happen to use this in your practice in terms of prescriptions? And do you have anybody that helps you with the sort of diet exercise portion of education? I'm just curious.
I'll answer that in 2 seconds, but one point I should emphasize is that in the trial we did, these trillion-dollar companies can do it right in terms of resourcing it very well. And so we had registered dietitian visits in both the treatment arm and the control arm with regular visits, and you can see the control group improved in the SURMOUNT OSA study, not because of placebo effect, but because diet and exercise are really given carefully. And so I do worry in a sleep clinic without adequate resources, you just start giving people injections and don't do the rest of it with diet, exercise, and dietitian visits and stuff. I don't know if we'll get the same results as we got in the trial. And certainly, as you're suggesting, the sustainability of the weight loss may not be there if people are not doing, skeletal muscle things to preserve muscle mass and resistive exercise, et cetera. So for me personally, I'm not doing that right now. Obviously, I have a conflict of interest. We have a very robust bariatric clinic at UC San Diego that's doing that, but they're now overwhelmed with volume, and so it's time will tell in terms of how best to address this. Ultimately, I think primary care physicians will have to get more familiarity with these medications as well if they haven't already.
All right. Well, that's just solidifying in my brain the thoughts about, yeah, it can be done, but you have to do it the right way. And it's really important for outcomes to be able to do that. And that might mean really kind of partnering with other people who can take the time, and their expertise is on that counseling piece of things. There are some earlier phase studies now. I saw a positive phase 2B study for a combination of atomoxetine and R-oxybutynin together. And I was wondering if obviously we need more trial data before you can make any conclusions, but I find it fascinating that we're looking toward, are there some additional therapies that might help improve tone of the upper airway? I don't know, are you hopeful for that as potentially adjunctive, or if someone really, just finds that they can't be compliant with standard treatment, a viable option for those folks potentially?
Yeah, certainly I'm optimistic that we'll come up with new treatments. Tirzepatide is one. There's others that are under development by us and by others. The combination drug that you mentioned, they did publish in the American Journal of Respiratory and Critical Care Medicine recently, called the so-called Mariposa study. Now, if you look at the intention to treat analysis, which is all the randomized patients, the improvement in the apnea-hypopnea index was about 5.9 events per hour, so it was good, but not amazing. They have 2 phase 3 studies that are ongoing now, and I think time will tell if those are home runs and they're able to treat sleep apnea effectively and it's well tolerated. Then, I think we'll all stand up and cheer and add one more new treatment to our armamentarium. There's concern with the medication combination about tachycardia and hypertension and side effects, those kinds of things. So again, that's why we do phase 3 studies, and we'll see what the risk benefit looks like when all is said and done.
Well, I have one final question for you, or maybe series of questions, but I wanted to get your thoughts because I know you've also done some work looking at, I think I recall hearing you talk about the Sunrise equipment, for example. But I wanted to ask and get your opinion on our standard, guys, when we do testing for at home is what we call a type 3 home sleep apnea test. And now there are more sophisticated testing where we can actually either do a type 2 home sleep apnea test or we can actually do a home polysomnogram. And I was just curious as to, I think these technologies are really cool. And they've, of course, have been sort of, when people come to you and talk to you about it, right, they obviously have an agenda. But what I like about it is for those patients where home sleep apnea testing, that's the standard testing, might be quite limited in terms of accuracy. I'm thinking for some of my patients that maybe have difficulty with sleep, insomnia, and maybe I'm not entirely suspicious of them, but I don't know that I'm going to really feel reassured by a type 3, a standard home sleep apnea test. So that in my mind is where those tests may have utility in particular. But I was just curious if you think the technology is there. They're they're FDA approved devices, and I know they're pushing for what we call a CPT code. So for those listening, that's how we bill for that. But in an ideal world, we could bill for it. I was just curious as to if you think those tests are where they need to be. Are there any limitations in your experience that we need to be on the lookout for if we're contemplating starting to offer that type of testing?
Yeah, I should disclose I worked with several of these companies just as by way of disclosure. I think you're right that it's a bit of a moving target and the field is evolving. The in-laboratory polysomnography can be quite cumbersome. It's a lot of wires and hookup and things, and we simply don't have the capacity to try and diagnose and treat everybody. We estimate about 1 billion people worldwide with obstructive sleep apnea, many more at risk. The idea that all those people get in-laboratory polysomnography seems a bit absurd, and so we do need home testing. Some of the very simple tests are probably less accurate. Some of the more detailed tests are probably more cumbersome, and so the happy medium is probably somewhere in between. What we are learning are a couple things. Number one is a single night tells you a little bit, but not the whole story. So things change night to night. There's night-to-night variability that's sort of biologic. People can sleep in different body positions or have more REM sleep or dreaming sleep some nights than others. They can drink a little bit of alcohol in one night versus another. And other things change over time. People gain weight or they lose weight or, these kinds of things. And so I think Danny Eckert had a paper in Chest trying to predict hypertension from a single night recording, and it wasn't very good. But then when he took multiple nights, it was really quite accurate. And so that night-to-night variability is not just random noise, but important biological signal in terms of predicting blood pressure is one example. So I think we're moving towards more and more technologies that can monitor multiple nights of recording in the home. The appeal of the home is that's a natural environment where people typically sleep rather than an in-lab setting where it's a bit of an artificial environment. And many of the home tests that are currently available don't assess sleep, they just assess breathing. But what I usually say, it's not a major feat of engineering to measure brainwave. And so I do think we should sort of hold the technology accountable in terms of we should be able to assess not just breathing, but also sleep when we're trying to assess sleep apnea.
Awesome. Well, I really appreciate your time today. I feel like I've learned a lot, and I also kind of verified some of these own personal hypotheses that I've been brewing in my less robustly research-oriented brain of mine. So I truly appreciate it, and thank you for spending your Saturday with me for a little bit.
Thank you. That was fun.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.